Welcome to the Deep Dive. Today, we're tackling a really significant aspect of surgery, the respiratory complications that can crop up, particularly in vascular surgery.
Yeah, and we're drawing heavily from the latest, the 10th edition of Rutherford's Vascular Surgery and Endovascular Therapy.
Our goal is, well, to go beyond just listing things. We want to really understand why these breathing issues happen, how they, show up.
And what we can actually do about them. Basically, giving you a clear picture of this whole area. It's
Yeah.
pretty critical for patient care.
And it really is important because these aren't like minor side effects we're talking about.
Not at all. Respiratory problems after surgery are a major, major contributor to patients getting sicker, and unfortunately, sometimes even to mortality.
So getting a good handle on this stuff, it can genuinely impact how we approach surgical care. Better outcomes, hopefully.
Exactly.
Okay, so let's dive right in. Who is potentially at a higher risk before they even get to the operating room? Where do we start with assessing that risk?
Right. So when we look at preoperative risk, it's really a mix of things. Factors about the patient themselves, specifics about the operation that's planned,
Okay.
and even some, key things we can glean from their lab work.
Got it. So focusing on the patient first, what are some of the big red flags?
Well, advanced age is definitely a significant factor.
Right.
Think about it as we get older. Our lungs, our chest muscles, they just aren't as flexible. It takes more work to breathe properly, get good gas exchange.
Makes sense. So older patients are more vulnerable.
Yeah. And we also look at something called the ASA score. It gives a sort of general picture of their overall health. An ASA score of 2 or higher, that points to an increased risk.
Okay. And smoking. We all know it's bad, but how much does it really hike up the risk for these specific complications?
It's substantial, really substantial. A history of smoking nearly doubles the risk. One big meta-analysis actually put it at about 73% higher risk for smokers.
Wow. That's huge.
It is. But the good news, the encouraging part, is that quitting helps. It really does. But it's not instantaneous.
Takes time.
Yeah, you need at least, say, 4 weeks of being smoke-free to see a noticeable drop in risk. And ideally, longer is even better. If someone's quit for over 3 months, their risk seems to be pretty much back down to non-smoker levels.
That's a really strong argument for quitting before surgery if you can.
Absolutely. A powerful reason to kick the habit.
Definitely gives you pause.
Yeah.
What other patient things should we be aware of?
Well, being male actually shows up as a risk factor. It's interesting.
Why is that?
The data consistently points to it, though the exact why isn't always crystal clear. Obesity is another major one.
Right, that seems intuitive.
Yeah, the extra weight, it puts pressure on the diaphragm, the chest wall. It just makes it physically harder to take those deep breaths, fully exhale.
It's like compressing the lungs.
Exactly. It literally reduces lung volumes, things like functional residual capacity, residual volume. We see measurable drops as BMI goes up.
And the numbers.
Obese patients are looking at roughly a 4.5 times higher risk for these complications.
Wow, okay. And sleep apnea. That seems to come up a lot more these days. How does that fit into the picture for surgery?
Obstructive sleep apnea, OSA. Yeah, it's actually more common in surgical patients than you might think, and often it's undiagnosed.
Right.
Around surgery time, these patients are definitely at higher risk for their oxygen levels dropping, for respiratory failure, even needing reintubation.
And the meds we use don't help, I guess.
That's a key point. Things like opioids, sedatives, they relax the airway muscles even more, which can make OSA worse.
Okay.
And studies back this up. Meta-analyses show higher rates of desaturations, respiratory failure, ICU transfers for OSA patients. We see about double the pulmonary complications, double the need for ventilators.
So if someone knows they have OSA and uses CPAP,
Using that CPAP machine consistently right up until surgery, that can be really beneficial, helps manage those risks.
okay, so sticking with the CPAP is crucial. What about folks with existing lung conditions like COPD or asthma? They already have breathing challenges.
Exactly. Those conditions mean their lung function is already impaired, so it just increases the odds of post-op respiratory problems.
Nonsense.
For COPD patients having aortic surgery, for instance, the complication rate can be as high as 40%.
40%.
Yeah, and COPD is also linked to worse long-term outcomes after EVR, that's endovascular aneurysm repair.
Yeah, and asthma.
Similar story. If asthma isn't well controlled, the complication rate is around 24%. But, and this is important, using systemic corticosteroids around surgery can slash that down to about 4.5%.
That's a huge difference.
It really is. Also, if a patient was hospitalized for asthma in the 3 months before surgery, their risk of post-op pneumonia is significantly higher.
So recent flare-ups are a warning sign.
Definitely. For elective surgery, if there's been a recent exacerbation of either COPD or asthma, it's generally wise to think about postponing, get things under better control first.
Good advice.
Yeah.
Any other patient factors to quickly mention?
Yeah, just briefly, things like congestive heart failure, being functionally dependent, or even having had an upper respiratory infection like a cold in the past month, those can all add to the risk profile.
Okay, that covers a lot on the patient side.
Yeah.
Now let's switch gears. What about the surgery itself? How does the actual procedure play a role?
The type of operation, and especially where it is on the body, that's really critical.
Okay.
Vascular surgery in general, particularly big operations on the aorta, like open AAA repairs, some types of bypasses near the groin, TVAR, these tend to carry a higher risk compared to lots of other surgery.
And location matters too.
Yes, surgery in the upper abdomen or inside the chest. That increases risk because it can mess with the diaphragm's movement, which is obviously key for breathing.
Right.
Interestingly, for a ruptured AAA, an open repair has more respiratory issues than the less invasive endovascular approach. Makes sense.
Yeah.
But for elective open AAA repair, whether the surgeon goes through the side, retroperitoneal, or the front transperitoneal, that doesn't seem to make a big difference for lung complications.
That's a subtle point. What else about the operation itself?
How long it takes. That's a big one. Surgery lasting longer than 2 hours, the risk starts going up noticeably.
2 hours is the mark.
Okay.
And anesthesia.
Anesthesia is crucial. Those neuromuscular blockers, the drugs that temporarily paralyze muscles, along with opioid painkillers and just general anesthesia itself, they can all dampen your natural cough and swallow reflexes.
Which leads to?
Buildup of secretions, maybe aspiration risk, just overall reduced ventilation.
Okay. Is one type of anesthesia better than another?
Well, there's some debate. Some research hints that maybe local or regional anesthesia might be better for certain vascular procedures like EVR or leg bypasses, fewer respiratory issues perhaps.
But not definitive.
No, other studies haven't found a significant difference, so the jury's still out a bit. Oh, and needing an endotracheal tube, plus using those long-acting muscle relaxants, those are also procedure-related risks.
Got it. Now, something I wouldn't have immediately thought of, blood transfusions. How do they link in?
Yeah, it's an important link. Even just 1 unit of packed red blood cells given during or after surgery, it's associated with a higher risk of needing early reintubation and other lung complications.
Just 1 unit?
Yeah. One study showed something like a 76% higher odds of pulmonary complications with just 1 or 2 units.
Wow.
And a huge factor related to the surgery is how urgent it is.
Emergency surgery versus planned.
Exactly. Urgent or emergency procedures. They carry dramatically higher risk. We're talking maybe 26% incidence of respiratory complications in vascular cases.
Why so much higher?
Well, usually the patients are sicker to begin with, their disease is more advanced, and critically, there's just no time for that preoperative optimization we talked about.
All right, you just have to go.
Yeah.
So even if someone's generally healthy, a long, complex, or emergency operation puts them at risk.
Precisely.
Okay. You mentioned lab tests earlier. What can those tell us beforehand?
Yeah, certain lab results can definitely wave a flag. Low oxygen levels before surgery, specifically an SpO2 below 90% on room air. That's probably the strongest single patient-related risk factor we can measure.
SpO2 below 90. Okay. What else?
Anemia. So a low hemoglobin, let's say 10 grams per deciliter or less, before surgery, that nearly triples the risk.
Suppose, okay.
We also see increased risk with high blood urea, nitrogen BUN over 21, and low albumin, which is a protein less than 35.
Got it. What about those tests that sometimes feel routine, like PFTs, pulmonary function tests, or blood gases, chest x-rays? Are they useful for everyone?
You know, they can be valuable in specific cases, but they aren't really recommended as routine screening for everyone having vascular surgery just to predict lung complications. The evidence just isn't super strong that PFTs or ABGs on their own are great predictors across the board. And routine pre-op chest x-rays, they tend to have a really low yield.
Meaning they don't often change things.
Exactly. Studies show only about 1.3% find something unexpected that actually changes the patient's management plan.
So when should we consider a chest x-ray?
Guidelines generally say think about it for patients who already have known heart or lung disease, or maybe for folks over 50 who are having a particularly high-risk surgery.
Okay, that makes sense. Focus the resources. Now, trying to pull all these different risk factors together. I know there are scoring systems or indices clinicians use. Can you touch on those?
Yeah, absolutely. These pulmonary risk indices, they're basically tools to help estimate the likelihood of respiratory complications.
Like a calculator.
Sort of, yeah. But it's crucial to remember they're meant to aid clinical judgment, not replace it.
Got it. Any examples?
Sure. There's the ARISCAT score. It looks at things we've mentioned: pre-op oxygen saturation, recent respiratory infection, age, hemoglobin, the type and site of surgery, how long it might take if it's an emergency. It's been validated quite a bit.
Okay, ARISCAT. Others?
There's the SLIP model, looks at surgery type, diabetes, COPD, GERD, alcohol abuse, and SLIP-2, which is more for patients already at risk for acute lung injury. It adds factors like aortic surgery, sepsis, emergency status, cirrhosis.
It's more complex cases.
Right. Then you have SPORC and SPOR2, the Las Vegas score, the Gupta calculators. Those focus specifically on predicting respiratory failure and pneumonia, and the Arizula index, mainly for predicting respiratory failure risk in men.
Wow, quite a few options.
Yeah, each uses a slightly different mix of factors to try and quantify that risk.
So these indices can be really helpful for flagging patients who might need, extra attention, maybe more preventative strategies.
Exactly.
Which brings us to the next point. What can we actually do to try and lower the risk of these complications happening?
Right. Perioperative risk reduction is key, and it spans the whole journey before, during, and after the operation.
Okay, let's break that down. What about things we can do before surgery? Preoperative steps.
This is hugely important preoperative optimization. We already hit smoking cessation hard, but it bears repeating. At least 4 weeks smoke-free makes a difference. Longer is better.
Got it. What else?
Patient education. It sounds simple, but it's powerful. Teaching patients about getting moving early after surgery, specific breathing exercises, it significantly cuts down on pulmonary complications.
How significantly?
One study showed a 75% relative risk reduction. Another found that just one focused session with a physiotherapist teaching these exercises led to much lower complication rates compared to just giving patients a booklet.
So really empowering the patient.
Absolutely. Pulmonary rehab programs can also help select patients, things like respiratory muscle training, chest physiotherapy, maybe using an incentive spirometer beforehand.
Does the evidence support that?
Yeah, a Cochrane review found that pre-op inspiratory muscle training, basically strengthening breathing muscles, reduced rates of atelectasis and pneumonia after surgery.
Interesting. So getting patients actively involved is a big win. What about managing their existing conditions?
That's critical. Getting OSA, COPD, asthma as stable as possible. This might mean vaccinations, optimizing bronchodilators or other asthma meds like leukotriene antagonists, maybe a short course of steroids.
Optimizing home oxygen?
Right, optimizing oxygen, sometimes even using NIPPV, non-invasive ventilation at home for severe COPD patients.
Yeah.
A small study showed fewer complications with that.
And avoiding triggers.
Yep. Avoiding environmental triggers, treating any active respiratory infections, correcting electrolyte imbalances. Oh, and addressing malnutrition is important too. And making sure OSA patients are actually using their CPAP leading up to surgery.
Okay, that's a comprehensive pre-op checklist.
Yeah.
Now, inside the OR, what can be done during the operation?
Several things. First, when it's clinically feasible, maybe choosing a less invasive endovascular technique instead of a big open surgery might lead to fewer respiratory issues.
That's a surgeon's call.
Absolutely. It depends entirely on the patient, the anatomy, the risks and benefits. Then, how we ventilate the patient during anesthesia is vital.
Lung protective ventilation.
Exactly. The goal is to protect the lungs. While the absolute best way is still debated, the trend is towards lower tidal volumes, the amount of air per breath, and limiting pressure in the airways.
What are the targets generally?
A meta-analysis suggests using PEEP that's positive end expiratory pressure of at least 5 centimeters H2O, keeping tidal volume around 6 to 8 millimoles per kilogram of ideal body weight, maybe using brief recruitment maneuvers.
But it's individualized.
Yes, expert consensus leans towards tailoring it. Start with those lower volumes and PEEP around 5, then adjust based on response. Use the shortest recruitment at the lowest effective pressure. Fluid management is also key.
Not too much, not too little.
Right. Goal-directed fluid therapy, where you monitor closely to avoid overload or dehydration, that's been linked to fewer lung problems like pulmonary edema, ARDS, pneumonia. The Fedora trial supported this.
Okay. And the muscle relaxants.
Need to be mindful. Higher doses increase risk, so making sure they're adequately reversed at the end is important. There are reversal agents like neostigmine and sugammadex.
Is one better?
Recent data suggests probably not a significant difference between them regarding pulmonary outcomes.
So gentle ventilation, careful fluids, manage the blockers. Got it. Now, after the surgery, this seems like a really vulnerable time.
It absolutely is. Postoperative risk reduction is critical. A big goal is early extubation, getting that breathing tube out as soon as it's safe.
Why is that so important?
Primarily to prevent VAP, ventilator-associated pneumonia. It's a nasty infection, increases mortality, lengthens ICU stays.
And it's common.
Incidence is maybe 27%. The risk goes up every day you're on the ventilator. About half of VAP cases happen in the first 4 days.
So what helps prevent VAP?
VAP prevention bundles. These are checklists, basically. Keep the head of the bed up, daily sedation vacations to see if they can breathe alone, good oral care, often with chlorhexidine, using oral rather than nasal tubes if possible, closed suctioning systems, strict hand hygiene.
Makes sense. What about general pneumonia prevention on the regular surgical wards?
Yeah, some hospitals have specific programs for that, focusing on lung expansion, mobility, multifaceted care. Studies like one from the VA and the ICOF East trial have shown really significant drops in pneumonia rates with these protocols.
What about those gadgets like incentive spirometers post-op? Do they help?
You know, the evidence for them used alone isn't that compelling. A Cochrane review found no solid proof they help after upper abdominal surgery, for instance.
What about non-invasive ventilation like CPAP or BiPAP after surgery?
That can be useful. It might help treat atelectasis, potentially reduce the need for reintubation, especially in obese patients where one meta-analysis showed benefit.
But the overall evidence is mixed.
Somewhat, yeah. Some smaller studies show benefits, but a big Cochrane review had conflicting results. There's an ongoing trial, PRISM, looking at perioperative CPAP. High-flow nasal cannula, interestingly, didn't beat standard oxygen in one major trial after abdominal surgery.
Okay. Pain control must be important too.
Crucial. Good pain control allows patients to cough, breathe deeply, move around. Epidural analgesia often comes out ahead of just IV opioids, especially for COPD patients, less respiratory depression, less pneumonia.
Multimodal analgesia.
Yes, using different types of pain relief together to minimize opioid use is the way to go. Also, avoiding routine nasogastric tubes for decompression, only use them if really needed for symptoms, as they've been linked to more lung complications.
And finally, nutrition.
Yeah, monitor nutrition status, encourage early feeding to get the gut working. It's important for overall recovery, though routine IV nutrition hasn't been shown to reduce pulmonary risk specifically.
Okay, a really comprehensive approach across the board. Now let's shift to what happens when these complications do occur. What do they look like clinically?
Right. We see a few common patterns. Atelectasis, as we've mentioned, is super common after anesthesia.
The collapsed air sacs.
Exactly. Alveoli collapse or fill with fluid. This messes with oxygenation, makes the lung stiffer, increases resistance in the lung's blood vessels, and raises infection risk.
It happens quickly.
Yeah, the biggest drop in lung capacity often happens within minutes of anesthesia induction. It can be caused by lots of things: anesthesia effects on surfactant, mechanical compression, changes in muscle function.
Does it cause fever?
That's a common belief, but the direct link isn't super strong, and using incentive spirometry just to prevent fever doesn't seem effective.
Okay. What about bronchospasm? That sounds scary.
It can be. It's the muscles around the bronchi tightening up, makes it hard to breathe, traps air, causes a mismatch between airflow and blood flow.
Common.
Not super common during surgery, but it can be life-threatening if it causes severe hypoxemia or hypercarbia, especially in asthma patients.
What triggers it?
Lots of things: intubation, extubation, suctioning, aspiration, surgical manipulation, certain drugs, pain, anxiety.
How do you know it's happening?
You might see high pressures on the ventilator, hear wheezing, see the patient struggling to exhale, poor chest rise.
And the treatment?
Fast-acting beta-2 agonists like albuterol inhalers, IV steroids. Severe cases might need IV epinephrine. Other things like anticholinergics, magnesium can sometimes help. But again, prevention via good asthma control pre-op is key.
Right. And then pneumonia, the actual lung infection.
Yeah. Acute infection of the lung tissue. It's the most common hospital-acquired infection, causes significant problems.
How is it classified?
We talk about HAP, hospital-acquired, starting 48 hours or more after admission, and VAP, ventilator-associated, 48 hours or more after intubation. The old category of healthcare-associated pneumonia isn't really used much anymore.
And VAP is caused by?
Usually microaspiration of bacteria that have colonized the patient's throat or airway. Common culprits are Staph aureus, Pseudomonas, Acinetobacter, E. coli, Klebsiella, often drug-resistant strains, unfortunately, like MRSA.
Diagnosis must be tricky.
It can be. The signs aren't always specific. We look for new infiltrates on the chest x-ray plus clinical signs fever, pus-like secretions, high white count, worsening oxygenation.
How do you confirm the bug?
Usually non-invasive sampling, like sucking secretions from the breathing tube, is preferred over more invasive methods, but practice varies. There's a scoring system, CPIS, but treatment decisions are mainly clinical.
And treatment involves antibiotics.
Yes, guided by local resistance patterns.
Yeah.
Start broad enough to cover likely suspects, including Staph aureus and Pseudomonas, then narrow down once cultures come back. There are specific criteria for when to cover MRSA or use double coverage for Pseudomonas based on risk factors and local resistance. Usually treat for about 7 days.
Okay, that's pneumonia. What about just plain acute respiratory failure?
That's basically when the lungs just can't do their job, protect the airway, oxygenate the blood, or get rid of CO2.
How common is that after surgery?
Pretty common, maybe 5–10% overall, but up to 40% after some major abdominal surgeries.
What causes it?
Loss of airway protection can be from anesthesia, muscle relaxants, swelling, bronchospasm. Then you have hypoxemic failure, low oxygen.
Caused by?
Things like pulmonary edema, pneumonia, sepsis, atelectasis, PE. Basically, problems with diffusion or VQ mismatch. Treat with PEEP, more oxygen.
In the other type.
Hypercapnic failure, high CO2 levels, often leading to acidosis. This is usually due to reduced overall ventilation or increased dead space. Think COPD, opioid effects, residual anesthesia, weak breathing muscles. Treat by increasing ventilation.
Key is finding the cause.
Absolutely. Need to figure out why it's happening. Many need intubation, but sometimes NIV or high-flow oxygen can work.
And then the most severe form, ARDS, acute respiratory distress syndrome.
Right. This is a diffuse lung injury triggered by some underlying insult, causes leaky blood vessels in the lungs, inflammation, loss of functional lung tissue.
How's it defined?
We use the Berlin definition, acute onset within 7 days of a trigger, bilateral opacities on imaging not fully explained by other things, and then severity based on the FaO2 ratio while on PEEP or CPAP.
Mild, moderate, severe.
Exactly. Mild is 200–300, moderate 100–200, severe is 100 or less. And mortality climbs sharply with severity, maybe 27% for mild, up to 45% or more for severe.
Pretty grim. How common is it?
Affects maybe 10% of ICU patients, 23% of ventilated patients in one study. High mortality and survivors often have long-term issues, cognitive problems, PTSD, weakness, depression.
What triggers ARDS?
Lots of things. Pneumonia, aspiration, trauma, sepsis, shock, pancreatitis, burns, transfusions, bypass.
How does it progress?
There's an initial exudative phase with inflammation and fluid leak, then a proliferative phase where the body tries to repair. Sometimes a fibrotic phase occurs if there's severe damage leading to scarring and worse outcomes. Management is complex.
Okay. And one last one. GRALI, the transfusion reaction.
Transfusion-related acute lung injury. It's respiratory distress, low oxygen, fluid in the lungs, maybe fever, low blood pressure happening within 6 hours of a transfusion.
What causes it?
Often thought to be a two-hit thing. Patient has some inflammation already, then something in the transfusion triggers a lung reaction.
Diagnosis criteria.
Yes, specific criteria about timing, oxygen levels, imaging findings, and ruling out heart failure as the cause. Important to recognize it quickly.
Is it common? Fatal.
Estimated maybe 1 in 5,000 transfusions. Mortality is around 5–10%, making it a top cause of transfusion deaths. But with supportive care, most patients recover well long-term.
Okay, those are the main complications. Let's move to management strategies. How do we treat these issues when they arise?
Right. The toolkit ranges from simple support to advanced life support. High-flow nasal oxygen, HFNO, has become really common.
What is that exactly?
Delivering heated, humidified oxygen at high flow rates like 20 to 60 liters per minute through nasal prongs.
And how does it help?
Several ways. Washes out dead space in the throat, makes breathing easier, provides a bit of PEEP, helps clear mucus, more comfortable for some patients.
Sounds good. Downsides.
The main risk is delaying intubation if the patient isn't truly improving. Need close monitoring.
What does the evidence say about using it after extubation?
It's mixed. Some studies show it reduces reintubation in lower-risk patients. Another found it wasn't inferior to NIV in high-risk patients. But the OPERA trial, after major abdominal surgery, showed no significant difference compared to standard oxygen for overall complications.
So, still some questions.
Yeah, exactly. Who benefits most, when to start it, when to escalate. Still being worked out.
Okay. What about non-invasive positive pressure ventilation, NPPV, CPAP or BiPAP?
Yeah, delivering pressure via a mask. CPAP is continuous pressure. BiPAP gives different pressures for inhaling and exhaling.
How does that help?
Reduces breathing work, pops open collapsed alveoli, improves gas exchange, shifts fluid out of the air spaces, increases lung volume. It's standard for COPD flares, pulmonary edema, and used in acute respiratory failure generally.
Does it work well after surgery?
Good evidence suggests it does, especially in post-op hypoxemia. Studies show it significantly reduces the need for intubation, cuts down on infections like pneumonia and sepsis, shortens ICU stays.
Particularly after abdominal surgery.
Yes, a Cochrane review found benefits there: less intubation, fewer infections, better blood gases compared to standard oxygen.
Any risks?
Some risk of stomach distension or aspiration, but generally safer than intubation. The key, though, is recognizing failure early.
Meaning?
If the patient isn't getting better on NPPV after an hour or two, delaying intubation can actually increase mortality risk. Need to switch to mechanical ventilation promptly if it's not working.
Okay. And when non-invasive isn't enough, we get to mechanical ventilation.
Yes, the cornerstone for severe respiratory failure, especially ARDS.
No.
Goals are to maintain gas exchange, rest the breathing muscles, and crucially, avoid ventilator-induced lung injury.
Volutrauma, atelect trauma.
Right. Which leads back to lung protective ventilation. Low tidal volumes, 4 to 8 millirelcoli predicted weight, keeping plateau pressure below 30 centimeter H2O. That's proven to reduce mortality in ARDS.
What about higher PEEP and recruitment maneuvers? You said they were controversial.
They are. Some meta-analyses suggest higher peak might help certain ARDS subgroups, but others show no benefit or even harm if recruitment is too aggressive. Recent big trials like ART showed increased mortality with a specific recruitment and PEEP titration strategy versus low PEEP in moderate severe ARDS. So still lots of uncertainty there.
What about other ventilation modes like HFOV?
High-frequency oscillatory ventilation. Trials haven't shown a benefit, and one large trial actually showed higher mortality, so it's generally not recommended for routine ARDS use.
So low tidal volume ventilation is the main thing. What about other therapies used with a ventilator? Adjuncts?
Several important ones. Prone positioning, turning the patient onto their stomach. Yes, for severe ARDS, guidelines recommend it for 12 hours a day. The Perseva trial showed significantly lower mortality with prone positioning for 16 hours daily.
How does it work?
Probably improves ventilation distribution, changes chest wall mechanics, reduces heart compression, improves VQ matching, recruits collapsed lung. Risks are low with experienced teams.
Okay, neuromuscular blockade. The paralytics.
Also controversial. An early trial, Acura-Sus, suggested benefit with a 48-hour infusion in moderate severe ARDS, but the more recent Rose trial found no mortality difference.
Why the different results?
Might be related to how deeply patients were sedated in the control groups. So the role of routine neuromuscular blockade is still unclear.
Fluid management.
No firm consensus. A conservative fluid strategy might improve lung function and shorten ventilation time, but maybe not mortality. Newer research suggests different ARDS subtypes might respond differently.
Any drugs that help ARDS? Steroids. Nitric oxide.
Unfortunately, no pharmacologic therapies have consistently shown a mortality benefit. Inhaled nitric oxide only gives temporary oxygen improvement, maybe kidney issues. Steroids, surfactant, not routine care for ARDS.
And finally, ECMO, the external lung machine.
Venovenous extracorporeal membrane oxygenation. It's an option for severe ARDS when nothing else works.
Does it improve survival?
Evidence is evolving. The CSAR trial suggested benefit, but had limitations. The ELA trial didn't show a statistically significant difference initially, but had high crossover, and later analysis suggested benefit. Meta-analyses do tend to find ECMO effective in reducing mortality.
So potentially important, but role still being defined.
Exactly. It seems important for refractory severe ARDS, but patient selection and timing are key, and research is ongoing.
Wow. So a really complex picture with lots of management options, needing very careful, individualized application.
Absolutely. Tailoring the approach is crucial.
Well, this has been an incredibly thorough deep dive. A lot to digest on a critical area of surgical care.
Definitely.
Just to quickly recap, we've covered how significant these respiratory complications are, the huge range of patient and procedure factors that increase risk, and importantly, the many proactive steps we can take pre-op, intra-op, post-op to try and prevent them.
And we've walked through how these problems show up from atelectasis to ARDS and the spectrum of treatments, from high-flow oxygen and NIV right up to mechanical ventilation and adjuncts like proning and potentially ECMO.
What's striking, I think, is how much we have learned, but also how much is still evolving, especially around managing severe ARDS, ventilation strategies, the role of ECMO.
Yeah, the research continues, and refining best practices is an ongoing process. Individualized care remains paramount.
So for you, our listener, we hope this deep dive gave you a really solid understanding of this vital aspect of surgical patient care. And maybe a final thought to leave you with. Reflecting on everything we discussed today, what factor or strategy stood out as most surprising to you, and what questions does it spark for future improvements in how we care for surgical patients?
Good questions to ponder.
Thanks so much for joining us for this deep dive.